bringing together voices in child and youth healthcare. This is CAPHC Presents.
CAPHC would like to thank the following member organizations for their generous support of our knowledge translation activities: the IWK Health Centre, the Children's Health Foundation of London, McMaster Children's Hospital Foundation, the Children's Hospital of Eastern Ontario Research Institute, the Children's Hospital Foundation of Manitoba, the Montreal Children's Hospital Foundation, the Holland Bloorview Children's Rehabilitation Hospital Foundation, the Children's Hospital Foundation of Saskatchewan, and Trillium Health Partners. We would also like to thank the following Keystone and program partners for their ongoing contributions that support all of CAPHC's programs and activities. If you have any questions or comments for our panelists, please type them into the question box at any time during the presentation. You can also share your thoughts and questions on Twitter by tagging @CAPHCtweets and using the hashtag CAPHCpresents. All of our webinars are recorded and can be found on the CAPHC Knowledge Exchange Network. Use the Ken to share these recordings with your colleagues or register an account and post comments, links, or other resources that you think will be of interest. And be sure to sign up for the CAPHC Presents weekly email newsletter to stay up to date with upcoming webinars and our recorded webinar archive.
Hello, everyone, and welcome to today's episode of CAPHC Presents. I'm Doug Maynard, the Associate Director at CAPHC, the Canadian Association of Pediatric Health Centers. And today we're going to talk about best practices for acute pain, and even better, we're going to make it easy for you, apparently. Well, I'm not going to make it easy, but we've got a great panel today that's going to make it easy for you. It's my pleasure to welcome everyone back after a short hiatus over the Christmas holidays, and it's also my pleasure to welcome today's panel as they represent a few of the individuals that have participated in and led one of CAPHC's communities of practice. This one being our community of practice in children's pain. This work, funded in large part by the BC Children's Hospital Foundation, began in 2012 and has culminated, all of our communities of practice work has culminated this year with a number of guidelines and toolkits. This particular one, the development of a toolkit of practices and strategies to help improve the assessment and management of children's pain, and today specifically acute pain. So it's a great opportunity to share the work of specifically of the CAPHC community and how we've really played a leadership role and leveraged our experts from across our community. So we do have a fairly large panel today, so I'm going to do just a quick introduction of everyone that's going to be joining us, but please do check out their bios on our Knowledge Exchange Network for more information. Today we have joining us Leeann Lukenchuk. Leeann is a nurse practitioner for the Pediatric Acute Pain Service at the Stollery Children's Hospital in Edmonton, Alberta. We have Karen Fleming, who is a clinical nurse educator for the pediatric unit at North York General Hospital in Toronto, and she's also a member of her hospital's interprofessional pain committee and the pediatric working group on her unit, where she'll be collaborating with team members to implement various aspects of CAPHC's toolkits. We have Dr. Naveen Punai, who is a pediatric emergency physician at the Children's Hospital at London Health Sciences Centre, and he's also a member of the Departments of Pediatrics and the Department of Medicine at Western University, where he also serves on Western University Health Sciences Research Ethics Board. We have Dr. Samina Ali, who is a professor of pediatrics and emergency medicine at the University of Alberta, and is also a pediatric emergency physician at the Stollery Children's Hospital in Edmonton, Alberta. Samina is also the co-chair of the CAPHC Pain Community of Practice. And we have joining us a little bit late, she's not with us yet, but hopefully she'll join us partway through, Dr. Jennifer Toole-Friedman, who is the medical lead for quality and safety at the Alberta Children's Hospital Emergency Department, and she's the medical director for quality and safety at the Alberta Children's Hospital in Calgary, Alberta. With all that, getting through all that, it's my pleasure to hand the virtual podium first over to Dr. Samina Ali in Edmonton. Over to you, Dr. Ali.
Thank you very much, Doug. I'm just going to pull up my slides for you all. And first of all, thank you to all for finding time in your day to join us to talk about best practices for acute pain. And we're hoping that with this presentation, you will find it less daunting and more easy to make changes, perhaps locally, provincially, or even more broadly. I just want to mention before we begin that all of our presenters are members of the CAPHC pain community of practice, and that none of us have any financial interest in any of the products or medications that are being presented. The objectives today, we'll break it down in three things, is just to understand or maybe really review, because I have a suspicion I'm preaching to the converted, as the expression goes, as to why pain matters. and then look at some evidence in action. So each of our toolkit co-leads will be giving exemplars of where they made change in their particular areas, and then ending their presentations with a toolkit exploration, so you can see where some of the tools that would facilitate that kind of change could be found on CAPHC's knowledge exchange network, and would be available open access universally. And then we'll finish or with 2 cross-center collaborative success stories. And after that, we'll open it up to all of you to share your stories, questions, comments with us. So why does treating pain matter? As I said, I'm sure the majority, if not everyone on this call, knows the answer to this question, but I think it bears a few moments of review and reflection, just because we sometimes get asked this by our learners, by our colleagues, and this is an opportunity just to remember why we do what we do. So pain is the most common reason for seeking healthcare in the Western world. So the vast majority of individuals who come to the emergency department, upwards of 80%, are coming because they have a painful condition, and similar numbers for other settings as well. The World Health Organization mandates that optimal pain treatment should be a fundamental human right, which is a statement that to this day still gives me goosebumps, because we're talking about fundamental human rights as access to food, shelter, clean water, safety, and optimal pain treatment. That's incredibly strong statement. And study after study tells us that we could do better. So how can we do better? How can we make that easier for us is the question. So our team over the last decade has done a couple of studies for a 360-degree evaluation to understand what people need. I've got 2 examples here. We talked to other healthcare providers as well, pardon me, or people who are part of the healthcare professional continuum. But just to highlight, on the left-hand side of your screen is a study we did with Canadian pediatric emergency physicians. And if you look at table 5, one of the top things they said was they wanted improved access to drugs, improved policies and procedures, and increased educational tools. Those are their top 3. And if you look at table 6, what would they like more in terms of education? They said evidence-based pain management, number 1 thing. So here we are with our toolkit 5 years later, or toolkits 5 years later, to try to address those concerns. Similarly, on the right-hand side of your screen, we asked ED administrators. So we asked over 100 emergency department administrators in Alberta, what would make it easier for you to implement better pain practices for children in your departments? And their number 1 barrier, they said, was education. And their number 1 change they wanted was additional policies and procedures and access to policies and procedures. And they said under required resources to do that, they needed continuing medical education and policies and procedures, protocols that were developed by experts. So we heard this as a community of practice. And for those who are interested, our nurses, our medical students, our residents, our emergency medical technicians, paramedics said exactly the same thing in slightly different words, if you will. So in response to this, we created these toolkits. So just one quick step back for what is a community of practice, because I'll be honest, I've been with the community for almost 6 years now, but when it was first introduced to me, I didn't know exactly what a COP was. So a COP is a group of people who share a concern or a passion for something they do and learn how to do it better as they interact regularly. I love this next part. This definition reflects the fundamentally social nature of human learning. And that's exactly what this was. To a T. It was a group of people who cared strongly, passionately, came together to try to make some changes. And so first off, there were 3 key areas of focus: procedural pain, acute pain, and chronic pain. And you can see in the parentheses when those are being presented, and chronic pain is coming very soon in just a couple of months. And for our acute pain toolkits today, we're going to talk about acute painful presentations, acute exacerbations of chronic disease, and perioperative pain. Those will be our focus or foci for today. And with that, I'll hand it over to Dr. Punai.
Okay, thank you, Samina. Good morning, everyone. I'm hoping that you can see my screen very clearly. What I'm going to talk a little bit about this morning is to share a local success story on an acutely painful condition, which we're all intensely familiar with, otitis media. So really, what are we going to talk about today? Well, the vast majority of emergency visits relate to pain, and these can be anything, abdominal pain, ear pain, fractures, etc. What we also know is that it's more and more difficult for clinicians to prescribe opioids and even to choose the appropriate opioid in the emergency department. And some of this is stemming from a lack of evidence over which opioid we should be choosing, who should receive opioids, and also parental and child willingness to accept opioids, because we need to practice in line with families' beliefs. So non-opioid, non-pharmacologic strategies are becoming increasingly important for the family. But the other piece that's really, really important for families is patient education, because the more they know, the better they are able to take care of their child once they go home. Remember, we're only seeing the tip of the iceberg in the emergency department in terms of pain management. What really matters is what happens once they leave our department. So we embarked on a way to make ear infections a little less painful for families, or at least give them the means to do so once they get home. 3/4 of young children have ear infections. And for those of you who are parents, I'm sure you're more than familiar with this. Now, interestingly, once they go home, what we haven't been able to focus on to date is that 1/3 of these kids continue to have symptoms. So even after we treat them in the emergency department and we give them a prescription for an antibiotic and give them some advice on analgesics, if that's your practice, a lot of these kids, a significant proportion, go on to still have pain and fever up to 7 days after we send them home. So it's really important to give them comprehensive discharge instructions and arm them with the information that they need to help minimize symptoms and also minimize medication errors. Now, video technology, online videos, and online educational modules have been found to improve the degree at which caregivers can do this at home in terms of their knowledge acquisition. And we've been doing this for many conditions in adults, many conditions for chronic illnesses such as diabetes and asthma. And recently we've found that we can also do this for things like fracture pain. So we thought we would try to devise a way and design an educational medium for caregivers of children who present to the emergency department with ear infections. And we were very excited about this project, and I'm just going to share some of the results with you. So how did we do this? Well, the first thing we needed to do is we needed to find out what were the barriers of providing analgesia at home. We had initially supposed that, the reason why kids are having symptoms a lot at home was because they were probably not being given analgesia, or their pain was not appropriately measured. So we looked at the published literature. We also did a local survey of parents. And we also did some in-depth interviews with some willing caregivers. And what we found was really interesting was there seemed to be about 4 or 5 major themes as to why analgesia was not provided at home and why pain was under-recognized once children left the ED. Parents were largely unaware of what to give. They were aware of analgesic options because it wasn't discussed in the ED. A lot of parents also felt that assessing pain in young children was difficult, and that's one of the reasons why the toolkits on the CAPHC website are so important. And I'll walk you through the toolkit a little bit later on. There's also a lot of misconceptions about pain. A lot of parents felt that, if we give an antibiotic, then that would manage their pain. And we all know this not to be true, and that antibiotics work well in conjunction with analgesia. Parents also had some concerns about side effects as well. And a lot of parents just said, look, I don't have time to do this. So what we did was we decided to design an educational video to help parents understand a little bit more about what their child could potentially be going through once they leave the ED and how to manage it. So we designed this 5-minute educational video, but we also showed it to our nursing staff, because remember, our nursing staff and our child life specialists are sort of frontline clinicians in this fight to manage pain once the child leaves. And it's our last sort of bridge with the family to get them to optimize care once they go home. And we thought the more the nurses knew, the more they were able to help families once they were discharged. So this discharge instructions video was primarily directed at caregivers, but we also gave it to some willing children as well, if they were old enough to understand. So let's have a look at what the video shows. I think we're going to be switching screens right now. Basically, this was a 5-minute video, and we were, able to get everything we needed in that 5-minute period.
Discharge instructions for middle ear infections, otherwise known as acute otitis media. This is an outline for this video. We will discuss why middle ear infections happen, the signs and symptoms your child may have, how you can care for your child with this type of infection, the recovery time, reasons you should go back to a doctor, and how you can potentially prevent these infections from happening. Middle ear infections are caused by a virus or a bacteria behind the eardrum. Most often, middle ear infections occur when a child has a cold. There is a tiny tube called the eustachian tube that connects the middle ear to the back of the throat. When a child has a cold, this tiny tube can get blocked by mucus, allowing fluid to build up behind the eardrum and get infected. Signs and symptoms of a middle ear infection include significant ear pain, fevers, which is a temperature greater than or equal to 38 degrees Celsius or 100.4 degrees Fahrenheit, difficulty sleeping, which may include crying more at night, seeming fussier than usual or very cranky, and not being as hungry as what they usually are. There are a number of things you can do to care for your child when they have this type of infection. They often have a lot of pain, and so it's important to treat it. Fevers in young children are very common. Although fevers are not harmful to your child, treating the fever will make your child more comfortable. You can give your child, for both pain and fever, ibuprofen, which is Advil or Motrin, or acetaminophen, which is Tylenol or Tempra. Please use the fever sheet we have provided you as a guide. We have calculated exactly how much medication your child can have based on his or her weight. It is important to give medication for both pain and fever to help your child feel better so that they can sleep more soundly and feel well enough to drink fluids to stay hydrated. When your child is feeling unwell, they may not want to eat. This is okay. But drinking is very important. Offer your child fluids often. You will know if your child is well hydrated if they are urinating or peeing their usual amount. Continue to breastfeed or formula feed your baby. They may require more frequent feeds. Offer your child a variety of fluids including milk, water, or an oral rehydration solution such as Pedialyte. Avoid sugary drinks like pop or juice. Please complete all antibiotics prescribed by your doctor even if your child seems better before they are done. Antibiotics may not be prescribed. Your doctor will decide what is best for your child. Your child can go back to school or daycare as soon as they are feeling better and their fever is gone. Middle ear infections are not contagious. Your child will likely feel better if pain and fever are controlled and if antibiotics are taken as prescribed within 48 to 72 hours of your visit to the emergency department. You should bring your child back to see a doctor if he or she continues to have ear pain or fevers 48 to 72 hours after your visit to the emergency department, if your child is not drinking and is urinating much less than usual, if you are worried that your child's condition is worsening. You can potentially prevent middle ear infections by trying to prevent colds by encouraging regular hand washing and by avoiding people who are sick, by keeping your child's immunizations up to date, by breastfeeding your child if possible, by avoiding feeding in the lying position. Instead, feed your child in the more upright position, by avoiding the use of soothers and pacifiers, and by avoiding exposure to secondhand smoke. Here are some key points from this presentation. Middle ear infections are common. Treat pain and fever with ibuprofen or acetaminophen. Keep your child well hydrated. Return to a doctor if your child has continued ear pain or fever 48 to 72 hours after your visit to the emergency department. If your child is not drinking and is urinating much less than usual and you are concerned about dehydration, or if you are worried that your child's condition is worsening.
Okay, so now that we've had a look at that online video, which is actually still available for anybody that wants to take a more in-depth look at it, I believe we can get the link to people somehow. And it's free of charge, of course. We can ask the next question, well, how did we do? So I'm just going to try to minimize the control panel here so you can see my slide a little clearer. So, of course, this video was used to educate nurses and allow them to facilitate discharge education, but it was more importantly given to caregivers. And what we did was we gave them a phone call about 72 hours later. And what we found with some validated instruments was that we were able to actually achieve subjectively a reduction in pain for that first 72-hour period, which is sort of your most important period when it comes to ear infections. That's when, the antibiotic has not really started working yet fully, and children still have some pain at home. But more importantly, we actually found that this improved functional outcomes. So in terms of how well the child ate, slept, when they returned to play. And that's really, really what's important to a child. We're very concerned about their pain, but they're not often able to voice that. And what they really want to do is just get back out and play and just feel like a normal child again. So that was really, really interesting for us to find. Caregivers overwhelmingly were very satisfied with this. They sort of rated it on a 5 out of 5 scale. So we were very, very happy with this intervention. So I'm just going to switch slides here now to go to have a look at the toolkit. I will take you through the toolkit. I have it on my computer. So this is the CAPHC toolkit for acutely painful presentations. And basically it starts off with just a little summary, but what you really want to get into here is the meat of it. In terms of the contents, it tells you exactly where you can find these contents. And basically these links just bring you down to further along on the website, on the web page, so that you're not having to scroll up and down. You can see everything very clearly in the content, on the content section here. Some of my, favorite things here are some handouts, and we can actually use these handouts in your emergency department or in your family medicine clinic or what have you, or a nursing clinic as well. And we can see that most of these are able to be easily downloaded. There's also some important features here on some clinical resources in terms of how you can manage pain and how you can assess pain. And there's also some links to some institutional policies available in both English and French. Now, what I really like is that there's also some videos here. A lot of people tend to respond to videos more than they respond to written information. And there's the famous video by Anthony Crocco here on pain management and assessment, known affectionately as the Rantony. And finally, if you're into doing some late night background reading, there's a ton of articles here on how to assess pain adequately and some analgesic options, and as well give a sort of a grand perspective on the scope of the problem. So with that, I will hand it off to the next panelist. Thank you for your attention.
Hi, this is Leeann, and I'm just getting my presentation ready. Can everyone hear me okay?
Yeah.
Okay, great. So I'm dealing with the Perioperative Toolbox, and I think it's very significant as we are just, 2017 marked the end of the Global Year Against Pain After Surgery, as designated by the International Association for the Study of Pain. And more importantly, this toolbox strives to provide better access to the evidence and information for anyone caring for an infant, child, or adolescent having surgery. A few facts: pediatric population is more vulnerable to pain management issues. We know that despite advances in pain evidence, significant numbers of children still continue to suffer moderate to severe pain when they're in our healthcare facilities. And then there's the obvious. Pain is a predictable outcome after surgery, and poor management of this can lead to obviously the short-term but potentially long-term consequences. The summary portion of the toolbox gets to this a little more, but I also want to highlight that there is a reference to the previous procedural pain toolbox that was launched in 2016, as we have to remember our surgical kids are also going to require painful procedures such as IV, starts, blood work, and things like that, complex dressing changes. I'm informed in my facility alone, the Stollery Children's Hospital in Edmonton, Alberta, that last year we performed 10,704 elective and emergency surgical procedures. And one of our challenges is that we are actually a children's hospital within the larger University of Alberta Hospital in Edmonton. So to start things off in some local initiative here, the next couple of slides will highlight two examples from our local pediatric pain handbook. And hopefully people have considered them as somewhat successful. This, I believe, is our fourth edition, and as you can see by the date that we have a lot of work ahead of us as well to update it. It was a publication created by an ongoing multidisciplinary pediatric pain management committee at our site, and is by no means comprehensive, but a brief overview of pain management, which includes acute postoperative pain management. We give this to incoming pediatric and surgical medical residents, new staff, nursing staff coming into orientation, and it sits as an online hospital resource for all staff. One example of the local work that is featured in this is we set out and developed a pain algorithm for nurses to reference, which includes postoperative pain. This took a couple years to pilot and complete and is by no means the only pain algorithm out there. We believe it's simple and easy to use and provides an example for decision making. And I think especially we were trying to target when nurses are trying different strategies to help with pain management, and it helps to let them know when to call and how to guide the conversation to what's been tried, what they've done, what's been effective, and what hasn't. And as you can see, the tool includes the 3 Ps because, of course, pain is multidimensional, and so should be the treatment. So we have the pharmacological, the psychological, and the physical approaches. And although many of us may look to some of the more pharmacologic pain control after surgery, we cannot separate the importance of the psychological and physical strategies for children. The next slide is a little excerpt from the handbook, the opioid section, and mentions codeine as not being suitable in the use of children, along with the link to the Health Canada warning. This is likely old news to you, but I believe it's important to mention in this forum because those of us, for those people caring for, or practitioners caring for children in places that are not dedicated pediatric health centers, this may be an issue. And certainly at one time, codeine was a very popular choice for mild to moderate opioid, as a moderate to opioid analgesic. And particularly in the province of Alberta, does not require one of our special triplicate prescriptions. And for those of you that are not aware or don't know, Alberta has a monitoring program for opioids and controlled substances that requires a special triplicate prescription. So this was another thing that we tried to tackle, and we were by no means the first ones to try to do this. But this is just an example of a document that exists and one of a series of documents that came out eventually with Alberta Health Services in an effort to address the mounting evidence that there were serious adverse events associated with using the prodrug codeine. And what seemed to start out as a discussion between a fellow nurse practitioner and anesthesiologist, it kind of built momentum, and our pediatric pharmacy and therapeutics got very interested, and this was pursued at a provincial level. And following the lead of our Eastern Canada counterparts, in June 2013, the decision was made to take it out of the hospital formularies for use in our pediatric population. And so just as a rollout and trying to get the message across, as part of the change strategies, our site had no codeine buttons for staff to wear, and that was hopefully to promote discussion amongst staff and parents about the issue. Summary documents went on mass circulation. Educational documents with graphics helping to explain the metabolism issues and subsequent danger to children. And then to the prescribers, there was also information sent out on alternate choices, opioid conversion charts, and how to obtain a triplicate prescription pad. So we kind of considered that this was able to be accomplished quite successfully, and that it's something that still stands for anyone trying to manage perioperative pain. Now I'm just going to go to the toolbox Okay, so it's full of excellent information, but I think we have to view it that it's a dynamic document. It provides some information that can easily be revised and added to, and I think it's got some very good information. When you look at the contents, there's many aspects. Thank you. To it. My eye as a clinician is drawn to some of the non-pharmacological clinical resources that exist in the document. The non-pharmacologic interventions, these kinds of things have the really pertinent developmental information in them and suggestions for what is most appropriate for, let's say, a certain developmental age that helps us be able to manage and maneuver when we're trying to select interventions effective and most relevant to the pediatric population that we deal with. Oh, thank you. So I see this as a really nice summary document that can help clinicians. Below it is also a developmental impact document. And this helps to ground me somewhat because as a clinician, we also need to look at just what hospitalization does and how it stresses and impacts children and what kinds of things can be issues at certain ages and what can be done to help mitigate any further stressors, because we have to remember these kinds of things are going to be on top of what is already a stress as having surgery and pain for a child. There's good information available for parents, which is key. About Kids Health has some excellent information. There are some French versions as well. And part of our perioperative pain management starts with parent and child preparation prior to surgery, and it's part of a continuum that needs to continue until they go home and they recover. I've mentioned mostly treatment for postoperative pain, but they're also within the perioperative kind of considerations. There's also further down references such as links to the good practice guidelines, and that talks more specifically about surgical procedures and possible pain strategies during and after surgery from a more medical point of view. And where applicable, Lisa's done a great job with some of the longer documents to try to highlight key pediatric areas. So under the section that refers to the RNAO, or the Registered Nurses Association of Ontario document, we've tried to highlight where the information is hidden, because we don't expect anybody to be perusing through pages and pages of stuff that might not be relevant to what they're searching for pediatrics. There's also some updates to some of the more classic, but maybe a little more dated information for things such as the Health Canada warning about codeine. So it's just interjected there with part of the items listed. Just in summary, again, this is a dynamic toolbox. It can be added to or revised as evidence or resources become available. Hopefully, it has some practice-ready information so that you can just take from with you and use, and some valuable references to help guide practice. But keeping in mind, we must always be prepared to individualize some of our strategies for specific patient care. And lastly, I hope this has provided an opportunity to make some contact with other care sites.
All right, so now we're going over to Karen Fleming. Over to you, Karen.
All right, thank you guys very much. Good morning, and again, to echo Samina's sentiments, we appreciate you joining us today. The toolkit that we were focused on was managing acute crises for chronically ill children, and we know that worldwide there's 20 to 35% of children and youth who have chronic pain, and so we really wanted to look at not only kids with chronic pain, but with any sort of chronic condition who then have acute exacerbations of pain. How can we help focus on that or help to manage that pain? So that was the key goal for our toolkit. Physical and psychological sequelae for children, certainly we see that manifest when we see our kids in clinic, or we see them, in our emergency departments. There's also emotional and social consequences for the family. There's also emotional and social consequences, certainly for the child themselves. But pain does not just reside with the child. It certainly impacts the entire family. Some examples of conditions that we were focused on: sickle cell anemia, migraine headaches, and rheumatological conditions. So for a local story, I'm focusing in on something that's for children with sickle cell, and it's a volunteer organization. It's called Camp Jamoke, which the link I don't have actually on the slide. So in case anyone wants to see more about Camp Jamoke, it's jamoke.org. So Camp Jamoke is a nonprofit organization that's focused on enriching the lives of children who are living with sickle cell disease. And the complications, one child at a time. It's been in operation since 1994, and certainly a special place for children living with sickle cell, because I can't say if it actually is still now to this very day the only camp that sends kids to a medically supervised camp for 2 weeks, but for sure over the last at least 10 years we were the only camp that did so. That children with sickle cell would be able to go to a camp, and it's not a camp just of children with sickle cell. It's embedded within a well camp, I guess is what you would title it. So they were embedded, say 30 or 40 kids would join a camp of about 200 kids. So then they would just all be mixed in together. So it's not like you're all children with sickle cell and not really getting exposure to different activities, different challenges that you might not be exposed to if it was a disease-focused camp. So it is a camp that we really want to bring back that normalization. As Naveen had mentioned, the whole trying to normalize things as much as possible. is certainly something I think Camp Jamoke has done well, and certainly families and children have voiced that as after they've had one of these experiences at camp. So over 600 kids have been able to attend summer camp so far, and we continue to raise money as a volunteer organization to see if we can send more children every year. So as I mentioned earlier, it is a medically supervised camp, so whether we send one doctor or a nurse practitioner, there is a medical person there, and then whether it's one nurse or two nurses, every week, there's at least one nurse there, and usually actually there's two. In case one of the nurses have to go off site with a child, there's always one then on the campsite available. And then that's actually paired along with the two camp nurses who would be on site for the general camp. Camp Winona, by the way, is the camp that we reside with. So there would be two other nurses there as well who really got used to having us there, who would, and when I say get used to, I mean they'd be able to support our kids if there was something we were doing, and there was a child who might be, waiting for us to get to them to help them out. They'd be able to help with the emotional, psychological pieces while we got another kid out of the health clinic if we were tied up with children. So nurses are available on site for the whole 2 weeks and for 24 hours of the day. And really our overall goal is to keep kids at camp as much as possible. So looking at non-pharmacological interventions up front, but also being quite aggressive with using combination opioids and NSAIDs. So we would make sure we did our Tylenol, morphine, ibuprofen type of combination that we would do around the clock, and we'd be really diligent about hydration. And the camp counselors as well would get education before we arrive, and every year we'd do kind of a little update, but just to make sure all the camp counselors knew about the importance of hydration, and if any kid is complaining of any little bit of pain, to make sure that they let us know, because they might try to hide it just because they don't want to be sent home. So just really having the support from the camp itself certainly helped us to achieve our goal. We had hospital and clinic affiliations as well, so if we needed to get an x-ray or if a child did need to be admitted, we were able to be admitted into the Ottawa hospital and then get transferred to sick kids, or in most times it was sick kids, to be honest, that they would then get transferred to. The camp itself did provide us transportation, which was of a huge help when we did need to leave the camp, and the children receive physical, psychological, emotional, and social support. So that was, as a few of us have mentioned, making sure we hit each of the domains for kids when we're looking at pain. Really looking at this from a holistic approach, enjoying time. Some of the things that kids will benefit from when going to Camp Jamoke is enjoying time spent with other children living with sickle cell disease. Certainly, some kids might not have that opportunity, especially in a school. There might not, there's not like a sign that says, "Hey, I've got sickle cell." So being able to come to a camp where you meet other kids with sickle cell and you can connect with them and know you're not alone really certainly helps with creating friendships and bonds that could last, because they're in and out of school so much, some kids anyways. The creation of friendships became quite challenging. So being able to do those type of normal activities certainly helped them and also helped to decrease their pain crises. We did get reports from families that after attending camp, they found their child was hospitalized less and had less acute pain episodes, which is exactly what we're focused on with this toolkit. The kids themselves had a fun camp activities. So they'd do archery, they would get to do canoeing, a variety of activities that they may not have the opportunity for. And I didn't mention up front that this camp is of no charge to parents, to families. The camp is completely supported by funds that are raised, and families pay, a $25 registration fee. But beyond that, the $2,300 it costs to send every child is raised by the organization. And we help hopefully enhance self-esteem for the kids, establishing that support network, lifelong friendships, as I also mentioned. So if we're going to look a little bit at the toolkit, a couple places that I think you might find has some good meaty information. It is set up like the other toolkits where you're able to see that there's clinician resources, family resources, PowerPoints, etc., like each of the other toolkits. And of course, they're just going to be focused more on treating acute pain for chronic conditions, and can also, of course, marry itself between toolkits because some of the information would apply across toolkits. But one that I certainly liked was a PowerPoint presentation done by one of the child life specialists, Play Away the Pain. And so BC Children's Hospital has some slides just to say, what is a child life specialist, meet the patient. I just think it's really kind of a fun way that you can introduce the role of a child life specialist to really understand how they can be used, whether you use this with new staff or you use this with patients and families to let them know how they can also advocate for child life to be involved in their, in the medical play for their child or the care, hospitalization of their child. I think that certainly this can bring some benefit if anyone's interested in that kind of information. And then the other one that I had liked was a document. There's lots of handouts and brochures, and the other piece taking us to About Kids Health webpage, which has been mentioned, has quite a bit of info on it as well. But the treatment of juvenile idiopathic arthritis. So here you can find quite a bit of info, again, medications for JIA, physical treatments, other types of care for JIA. So you're able to kind of navigate through whatever is relevant for you and your patient at that time, and as well as translated, which I do really love about the About Kids Health website, is that the entire webpage can be translated into French or simplified Chinese, and then documents themselves, some of them will be translated, and you can find that on their webpage. At the very top are the languages that are available, but to find the documents and then find the language so you actually can read the document, you'll be able to find that. I believe it's through Health A to Z, yes, and here, multilingual, you can find other documents there. Okay, so of course we have families who have limited English proficiency, so this would certainly help support their needs. And those are the two, and that was my other one. So the toolkit for GIA is the other piece I just went through. So thank you very much for having us today.
All right, so we're going to go back to Dr. Samina Ali just for a short piece on PERC. Over to you, Dr. Ali.
Thank you. So PERC is Pediatric Emergency Research Canada, and it's a network of researchers, clinicians, educators interested in bettering and improving pediatric emergency care across Canada, and includes the 15 Canadian academic children's hospitals. And a few years back, myself and Dr. Punai, who's also on the call, created a pain interest group to try to really focus on the goal of encouraging high quality pain management practice and research, and to make sure we had a stewardship of trainees as well. And the idea was that we had larger centers, or larger in the sense that they were well established with their research programs, working with centers that were trying to establish better quality research or improve pain management practice, and then we would all work together. This is just an example in the last 4 years of the kind of projects that have come out of this: systematic reviews, national surveys, randomized control trials, and these were efforts across the nation. And these are truly Canadian studies, which is incredible that we've already seen so much fruitful results from such a young group. And the future projects coming in the next 3 to 4 years for this group include planning of an intranasal fentanyl trial that is being currently developed, an intranasal ketamine for procedural sedation trial that will be implemented this year, and an oral hydromorphone or dilaudid trial that will be implemented this year as well. In terms of what have we learned from this group and participating, I think very briefly, it is an incredible place to find support and encouragement. But it is difficult to maintain connections across the nation, and we're learning how to best do that to keep people feeling engaged. We realize that it's worked really well to connect mid-career and senior researchers to work collaboratively. And you saw in the previous slide those incredible large studies that were able to be done. But what we want to focus on now moving forward is to ensure more creative ways to make sure our more junior colleagues, or piglets as we like to call them, are engaged during their training, so that we can all retire and they can take over. And so happy to talk about this more offline or afterwards, and please feel free to connect. But I'll hand things over to Dr. Till-Friedman now.
All right.
Can everyone hear me? Great. Yep. Thank you. Thank you, everyone, for the opportunity to share this project that has been near and dear to my heart for the past few years. We call it the Alberta Emergency Department Commitment to Comfort Quality Improvement Collaborative. And this is going to be a pretty quick overview. So I do want to let you know we do have a project website, commitmenttocomfort.com, and that has contact information links on the website if you want more information or you want to get in touch with us about the project. So we started doing this work over 3 years ago now. I think all of us on this call can appreciate that treatment of pain is a very high priority for patients and families that visit emergency departments. And we all know that undertreated pain causes short and long-term harm. We decided to take a look at how we were doing in our own emergency department at Alberta Children's Hospital. And we started out by focusing on limb injuries, not because that was the only condition that we cared about, but because that was one of our most common painful conditions that we see in the emergency department. And in fact, it's 14% of all of the visits to Calgary emergency departments by children in general. And what we learned is that even in our pediatric emergency department, only 28% of kids were receiving analgesic medication for their pain. And what we didn't know is of that percent, how many actually, or of those kids, how many would have wanted pain medication and we weren't reaching them? How many were being offered non-medicinal options for treating their pain? And what was the patient experience? We really, when we started out, just had our limited amount of data available to us. But what we were able to see is that even when they got pain medication, the median time ranged from 24 minutes at the Children's Hospital, which was okay but not great, all the way up to over 2 hours at some of the general emergency departments in the city of Calgary. So we got to work. And what I'd like to share is that we used quality improvement methods. And I would like everyone to recognize that these methods are actually quite simple and not at all inaccessible for novices. So I'd like to call your attention to what's called the model for improvement on the right. And if you just want to have a good understanding of quality improvement, just focus on this model. What it means is that when you're doing quality improvement work, you ask yourself at the very beginning, what are you trying to accomplish? And you think about that in terms of performance or what it means to the patient. So not just that we want to implement the toolkit, which is a wonderful thing to do, and it certainly will probably bring about benefits, but how will you know that? So from a patient perspective, what are you trying to accomplish? So we focused on certain measures. We focused on timeliness of analgesia. We had measures of patient experience, but we had performance measures. And so we used things like the toolkits to reach our performance measures. The next step in the model for improvement is how do we know that a change is an improvement? So that focuses on what are you actually going to measure? And it's quite hard to improve something when you're not measuring it and you don't have that way of giving yourself feedback about how well you're doing. And then finally, the third question in the model for improvement is what change can we make that will result in improvement? And the reason that that's an explicit question is that usually one change is not going to get you toward your goals. And so in quality improvement, you do plan, do, study, act cycles. So you plan tests of change, and then you look at how close that's getting you toward your goals. If it's getting you closer to your goals, great, keep going. If not, you have to think again. And so we put together a comprehensive package. And in speaking with patients and families and getting a lot of input, we developed something called the Commitment to Comfort. And what that says is that we'll do our best to promote comfort by helping to lessen pain and distress. And so that was adopted as a philosophy in our emergency department. It's since been spread to our whole hospital. And we put together these kits of distraction items. We had materials that we developed internally. We borrowed heavily from resources through CAPHC as well. And so we had posters with pain skills, posters letting families know that they can get topical anesthetics for needles, posters about comfort positions that we put in places where families could see, so that they would know that if staff weren't inviting them to, for example, receive an IV in a seated position or being held in a parent's lap, that those were things that were available to them. So we put together this package through lots of tests of change. And we then set about doing our work and measuring whether we were achieving our goals. We did do a lot of we collected a lot of patient-reported outcomes in our initial work as well. And so we were very encouraged to see that we were making change. And so we wanted to decrease the proportion of children in pain who weren't offered pain medications, and we were able to do that. We also looked at a measure of dissatisfaction. I think most of us know that satisfaction alone is not a good measure of knowing how well that you are treating pain. Families might report that they're satisfied, but that's maybe because they knew that you tried your best even though you weren't effective. But we really felt that we wanted to eliminate dissatisfaction. And so that was one of our measures as well. And in the graph, you can see the impact of the work done through the City of Calgary when we started first in the Alberta Children's Emergency Department in April of 2015, and then spread to the other 3 emergency departments in Calgary that see children in April of 2016. Our target for the proportion of visits of children who would get an analgesic medication was 40%, and that was actually based on what patients and families told us, because some of the kids actually weren't in significant pain when they arrived with a limb injury, and some had already received analgesia. So we were able to meet our target, and we also decreased the median triage to analgesia minutes from 37 minutes down to 12 minutes. And in fact, at the Children's Hospital right now, our median is 7 minutes from arrival to analgesia for a limb injury. With the success of that work, which I'll say was due in no small part to the dedication of the teams in the general emergency departments. One wonderful thing about working in this area is that I think there's a universal appeal to wanting to improve a child's pain experience in an emergency department. So engagement has never been a challenge in this project, and that's really wonderful. It is really exciting to work with teams at other sites that are really excited about working with us, learning a little bit of basic quality improvement methods, and then learning about the content of why we treat pediatric pain and how, and then going about and doing their work. So we invited all of the emergency departments in Alberta to participate in this work. We sent communications to unit managers, physician leads, and nurse educators, and we actually have had 51 sites now participating out of 108 emergency departments in Alberta. 38 of these sites are actively doing work right now. And we have added also a measure of procedural pain. So we started out focusing on limb injuries. We are now also looking at the proportion of children who are age 0 to 12 who receive a topical anesthetic prior to their needle procedure for labs. And the way the project works now as a provincial QI collaborative is that each site has formed their own project team, which usually consists of a nurse educator or a bedside nurse, and usually a physician lead. All the sites have organized themselves a little bit differently, but they have their teams and they set their own performance goals. And we ask them to audit a very small number of charts, just 10 charts a month. And these are paper charts in most of Alberta. And so they are reporting them onto an electronic survey called REDCap, and that then goes into a database. So we're actually able to look at improvement provincially. So all the sites that participate then get a comfort kit, and they participate in monthly webinars, and they are shown resources such as the CAPHC pain toolkit, which they use to build their own improvement programs in their emergency departments. And we are seeing some early success. So the teams just started to do the improvement work over the past fall, and these graphs show their audits of their charts from the previous year, and then starting in the midsummer to early fall, some of the teams started to do their improvement work. And so we're really encouraged to see this provincial work. 38 sites have contributed to this data, and the proportion of children who are receiving a pain score for their fracture has gone from a provincial median to 24%. Now we're seeing in the last month above 40%. And the proportion of kids 0 to 12 who are getting a topical anesthetic before their needle procedure, previously a provincial median was 13%. And the last couple months, we've seen numbers around 30%. So we're really encouraged that it seems that the project is having impact. And really, I think the factors for the success, like I said, this is something that the local teams really care about. And so they are very engaged and they're doing wonderful work at the local level. And I think just a little bit of QI knowledge goes a long way. So I think when you actually look at your performance, then it really motivates people, because this is something that people care about. And when you can see what your performance is, and then you're given just a little bit of support through things like the toolkit, or through collaboratives such as ours, then you can really see a lot of positive impact. So we're very encouraged about this work, and the CAPHC resources have been really instrumental in giving all of our local teams the resources that they need to be successful. Thank you.
All right, and I believe with that, Dr. Ali, maybe you can correct me if I'm wrong. I believe that completes the presentation portion of today's webinar. Certainly a wealth of content, and we do have a few questions here. We have about 2 or 3 minutes left, so if anyone does have any other questions for our panel, we will try and squeeze them in. But we do have a couple questions that came in now. Dr. Punai, the first question came in related to the video. There was a number of individuals who were interested in accessing the video, wondering if they could use the video. What rights would is there? To get rights to show it on their hospital TV, for example, et cetera. Is there any chance that they could access that video?
Yes, they can. I can certainly send the link out. There are no copyrights or patents on the video. It was developed for public use within the healthcare arena. So yes, I mean, feel free to use it. I don't anticipate it being taken down anytime within the next 18 months.
What's that? Is it possible that if we could add that to the toolkit on the knowledge exchange? Absolutely. And I can provide those details, and I can either provide the entire video in an MP4 format, or a link to the video. Okay, well, we'll certainly we'll work with Lisa Stromquist, who coordinates our communities of practice, and we'll get that information up there. So please do stay tuned to that. And if anyone does want access to the video and can't find where we end up putting it, just don't hesitate to contact us here at CAPHC through our website. A number of other questions were related to sort of implementation, and I think there's sort of the general frustration with getting good pain practices in place despite the wealth of knowledge and research that has existed for years. It's been difficult to get practices in place in many hospitals. Many of you have talked about sort of lean approaches and PDSA cycles and quality improvement approaches and that sort of thing to get this in place, and you've had success with those things. A number of the questions are sort of asking more around, maybe you could talk about, and maybe a few of you could give us examples of what you have found successful within your own organizations, knowing that all organizations are different culture, different community, different relationships in place in your organizations. But what has made it successful in your organizations outside of the big ticket items like quality improvement strategies at large? Do you have any stories that you could share with us that made implementation easier for some of these things?
This is Jennifer. I'd be happy to answer that, because we actually got off to a slow start. I mean, our project looks great right now, but our start was slow. When I started doing this work, I started focusing on something that I quickly realized didn't matter that much to our group locally, which was electronically recording our pain scores at triage. I think our nurses were assessing pain, but we were looking at the recorded pain scores, and it just wasn't engaging to the group. And so I had to kind of take a step back and rethink. And one of the things that helped is that we were actually collecting some patient experience surveys, which we did in the beginning through a student volunteer, just handing these surveys out to families, getting some quotes, both good and bad. So the good quotes would get people excited and engaged. The quotes of experiences that weren't so great would actually motivate people to do better and provide a little bit of evidence that we weren't maybe always as good as we thought. And then we actually had some fun with it. So when we implemented Commitment to Comfort, we actually had a staff comfort week, and we had a pretty small project budget, but I used a chunk of it to have a day where we had pizzas and various kinds of comfort food during a few shifts. And I even put all of our materials in one place. And I actually booked a local massage clinic to come, and they were scheduled in the we had a nursing break room, and people had like the ability to come. Now that was extravagant, but it's just an example. But we actually, that was to raise awareness and get excitement about comfort. So we had a staff comfort week, but we talked all about pediatric comfort and comfort for our patients. And we made it really fun, and we shared early successes. So we changed what we were focusing on to actually the proportion of kids that got analgesia, and that was something that meant a lot to our nurses. So I was able to create early successes and positive feelings, and then keep the momentum going and build off of that. And that worked really well for us. And the comfort kits, even though honestly they're not expensive, it's like $50 to put together a comfort kits, but our staff really liked having the comfort kits, and it made the project really visible. So the visibility, the engagement, building on early successes, and being staff and patient-centered in the approach that we were taking, I think those were all the keys to success.
Well, I think that was a great answer. I think there was lots of, despite that's specific to your implementation, I think some of those were great examples of how you can engage people in any of these tools and helping implement them in your organization. That was a great answer. Thank you very much. We are a bit over time. We usually try to go through our panel and have any closing key messages, but I don't know if we have the time for that. So maybe Dr. Ali, as the co-chair, as the one co-chair of the two co-chairs that are here today, maybe you could just sort of close us off with sort of a final sort of closing comment that you would leave, or a key message you'd like to leave the audience with before we wrap up.
Thank you, Doug, and thank you to everyone who stuck it out to the very end of this session. I think the bottom line is that pain belongs to none of us and all of us. And so what I mean by that is that it's not specific to any specialty or any healthcare profession. We all share it. And as we're talking about the vulnerable population that children are, that we need to continue to work together with these amazing resources and help one another. So I hope that it's not only that the toolkits are available to everyone, but that you recognize that the people who are contributing and who are part of the community of practice, I imagine I speak for everyone when I say they would welcome someone reaching out to them and asking for help to make this happen at your center.
Thank you very much, Dr. Ali, and to the rest of the panel. And I think you said it best at the beginning with your description of the community of practice, that shared learning experience, or the human sort of nature of it all. And I think I totally agree that if anyone does want any more information, they're welcome to contact Lisa here in the office, and she can certainly connect anyone with the relevant content experts that either presented here or have participated in the work throughout the last 5-6 years, however long we've been doing this. So thank you very much to the panel. Great presentation. We did have a question asking about where they can find all these informations in one site. All of these resources are available or will be shortly available through the Knowledge Exchange Network on the CAPHC Knowledge Exchange Network at ken.caphc.org. There's a toolkit section, and that will take you to the pain toolkit, which is broken up, as we saw today, into the acute procedural pain, the acute exacerbations of chronic conditions, and the forthcoming chronic pain information that will be up shortly. So you can always go there to get to information, and that will send you off to the various hospital and other organizations that have contributed to this work. So that's probably your best place to start. And if there's anything that you're looking for that you can't find there, please, again, don't hesitate to contact us. All right, and with that, I think we'll wrap up. We do our webinars every Wednesday at 11 a.m. a.m. Eastern Time. It's always great when you can watch live, as it is your chance to ask some questions and participate in the discussion. But when you can't watch live, we do record these sessions and make them available also on the Knowledge Exchange Network, as well as a copy of the PowerPoint presentations and other resources that might be made available. Next week, our next webinar will be January 31st, where we will be talking about sharing data without sharing data. There was a change in the schedule, so if you had already registered for that webinar or were aware of it, we did change the date to January 31st. And in this webinar, we're going to hear from our colleagues at StatLog Econometrics, who have been supporting a project called PCORE and PCORE-Net, which is in the United States, but they've used a common data model to overcome many of the barriers that exist when attempting to share hospital data across different organizations and across jurisdictions. And this project has allowed hospitals to make a national data set available to hospital administrators and clinicians across hundreds of hospitals for the purpose of really directly supporting decision making in those organizations. And then following that, we have sort of a double header on health information and data. On February 7th, we're going to have hear about the information age and improving and transforming the Canadian health ecosystem. And in this session, we're going to hear from our colleagues that developed the Pediatric Rehabilitation Reporting System, and they're going to give us some insight from their inaugural report that they just produced this past year. And they will lead a discussion on the challenges and successes that were overcome when implementing a national data reporting system in the rehabilitation sector. So some great stuff coming up in the next couple of weeks. Thanks again for joining us today for this great presentation. Thanks again to our panelists for this great information and for all of their work in the community of practice in creating the pain toolkits. And hopefully we'll see everyone back here in a couple of weeks for our next webinar. Bye, everyone.